Hello, everybody. My name is Trent Maruyama, and I'm the Program Manager for Rehabilitation Technology at Barrow Neurorehabilitation Center. I would like to thank For Intelligence and the organizers of the GReAT Symposium for giving me the opportunity to speak at this spectacular event. My talk will center around the current use of robotics in the rehabilitation program in the USA and the future direction of rehabilitation robotics. Why do we choose to use robotics? Well, at Barrow, we're trying to follow our mission statement for both Barrow Neurological Institute and Barrow Neurorehabilitation Services. It is ingrained in our mission statement to advance the knowledge and practice and innovate clinical techniques and technology through research and evidence-based practice. We believe that conventional therapy is a very valuable part of the rehab program. When possible, we try to add robotics to their conventional therapy. By doing this, we're working to determine what is the optimal balance of conventional therapy to robotics, and what is the right mix of that. That hasn't been shown yet. Many people believe the more repetitions and more dosage you get, the better it is, but we're trying to find the right mix. And also that fits within our reimbursement and our therapy programs, because we'd love to give as much extra therapy as possible, but sometimes we can't physically do that. The other issue is that varies not only it varies per diagnostic group, such as spinal cord injury and stroke, but it also may change on an individual basis on what people like and how they view some of the extra therapy they're providing. And at Barrow, we use many different types of robotics in the clinic. These can range from the ones we have here, such as the bionic arm hand, the Recesso ESO glove, Myomo MyoPro, Tyromotion Diego, Exobionics GT or NR, Indigo Therapy, Fourier Arm Modus M2, and the ReWalk Restore. But also, besides robotics, we have many other types of technologies that we use. As you can see by this list, we have a good fortune at Barrow to have a variety of technologies that we can use with our patients. I see this like having the right tool to treat your patient at the right time. Having a variety of tools gives the therapist more options to customize their interventions in the most appropriate manner to meet the needs of the patient. The therapists use these clinical decision-making to choose the appropriate devices at the appropriate times. And these technologies include things like the Hocoma, C-Mill, Tyromotion devices such as the Miro, Timo, and Pablo, Synchrony swallowing device, Xeno Walkway, the Terrain Hopper, and others. But as you can see, why we've chosen to use robotics, and it's based on some efficacy studies. One being the American Stroke Association Guidelines for Adult Stroke Rehab and Recovery. And here, the Stroke Association has classified what devices should be used and when. And this is based on research. So class 1, which are the green boxes, are conditions for which there's evidence for and/or general agreement that the procedure or treatment is useful and effective. We would love to see robotics in the green section all the time. But right now, where they're at is in more the yellow section for us. And class 2, which is the yellow section, are conditions for which there are conflicting evidence and or divergence of opinion about usefulness or efficacy of a procedure or treatment. Here, the benefit is greater than the risk. And in class 2, it's also subdivided into class 2A, which shows the weight of the evidence or opinion is in favor of the procedure or treatment. And class 2B is usefulness or efficacy is less well established by evidence or opinion. So as I break this out, and I'll show you upper and lower body robotics separately. So for lower extremity, we have been classified as class 2B. And it basically states that robot-assisted movement training to improve motor function and mobility after stroke in combination with conventional therapy may be considered. And it says may be considered, where it says risk is a little bit benefits a little bit bigger than risk. So the lower extremity robotics hasn't been as well proven to continue to help patients as we go along. There's been both good studies that show that and studies that didn't. For upper extremity though, you see as a class 2 that the benefit is much greater than the risk. And robotic therapies are reasonable to consider for deliver more intensive practice for individuals with moderate to severe upper limb paresis. So even with all the studies, there are times when the studies don't always show you everything you need to see. And at Barrow, we've worked at different ways to help use the robotics with different people and populations of patients. And in this video, I'm going to show you, Alec is a patient who presented with a lot of compensatory gait strategies right after his traumatic brain injury. And in this case, because the therapist didn't want him to learn those compensatory gait strategies, he chose to do overground training only in the ExoGT. And he did this until Alec was able to show less compensatory gait strategies and have a bit more normal gait pattern. So I'm going to show you Alec's kind of story a little bit real quickly.
When I first got admitted into inpatient rehab here at Barrow, I wasn't able to walk, talk, eat, to say the least, and I got fitted for a wheelchair a couple of weeks before I got discharged from Barrow, but by the time I was discharged, I didn't need the wheelchair anymore. I walked out of the hospital with the cane.
And Alec didn't meet some of the criteria that was identified from the device. He couldn't follow instructions very well in the beginning. He wasn't communicating very well. So some of these issues are things that would have been contraindications for the Exo. But our therapist made a good clinical decision to how to use the device to make sure that that device was the best thing for the person at the right time. And understand that robotics are a tool, and our therapists are the ones deciding which tools to use. So in rehab, there's been a lot of things that change. But over the course of the last 70 years or so, there hasn't been a lot of treatment philosophies that have come up and changed how we provide therapeutic intervention. So are there new treatment intervention approaches? Not really. So from the past, NDT back in 1948 from Berta and Carl Bulbach, PNF came into being from 1945 to 1950 by Herman Kabat. And then there was constraint-induced therapy from 1993 by Taub. So we see that in the last 70 years, there hasn't been a lot of new treatment modalities. And even NDT, if you look in that stroke paper that I showed you earlier for robotics, doesn't show a lot of good evidence-based practice. Yet we do see with using it that it does seem to help patients progress further along. So what is changing now then? Materials and technology are closely linked with each other. The changes in materials are allowing fabrication of smaller and lighter motor actuators, new textiles, power supplies. For example, are all areas where material science continues to push the boundaries of what we think materials can do. And technology, as we all know, is a rapidly changing field. The question is, how do you make this technology materials work with our bodies and restore functional ability? So that being said, we have the device. How do we control the devices? Are there passive controls? Is it controlled remotely? Is it done by the movement of a patient's body parts that drive the device? Or does your brain, using motor intent, move the device? Those are all the things we're looking at, and those are parts of the ways that commercially based robotics are now being utilized. So those human-machine interfaces come in a couple different ways right now in commercial robotics. One is more of a force sensing tactile-based system. Some are electrical biological signals, and those could be either electromyogram, EMGs, or electroencephalogram, EEGs, for the brain-computer interface. So first, let's look at what's mostly on the market. Commercially right now, most of these robotics that are in the available for use in rehab are more force sensing. So some examples of those are lower extremity, like the Exobionics NR, the Indigo Therapy, the ReWalk robot. And for upper extremity, things like the Fourier Arm Modus M2, In-Motion Arm Hand, and the BERT are all examples of different types of force sensing devices. And those are good, but they lack the ability for the robot to interpret what the patient wants to do. It's all reactionary. So another type, as we talked about, is the bioelectric signal interfaces. And one is EMG. And we use Myomo at the clinic. But what I want to do is I want to show you a little video of what a gentleman thought of the Myomo. And this is, he's 2 weeks post his stroke. And let me give you what he's...
I felt it through my joint because when I fired the tricep, it assisted it, so it allowed me to do it allowed me to minimize the amount of work I had to do the motion, because the less I have to think about it, it becomes more natural. Every time I fight stuff, I waste a lot of excess energy trying to fire different muscles, like a baby trying to learn. And so what I got, and what I believe I got now, because this is new, I didn't know this till just now you're asking me, but I'm feeling that feeling, it feels more connected right now. It felt more natural, and I can say this is just from whenever that session ended, about what, 8:30? Mm-hmm. So in this time now, that's still there. I'm not shitting you, man. It's astounding. And yet, I mean, I could be doing the same thing with a therapist, and so that just made it quick. It seemed like it helped. And I got that force feedback, which I like, because even which it existed. That's by definition cool stuff, really cool stuff.
Thank you.
Really is good stuff. You guys are doing good work.
So Jim was talking about what the device did for him, and he talked about a lot that he didn't have to think about it as much. And that's some of the things that the bioelectric type interfaces will allow you to do. So it's intent versus having to work really hard to get the muscle to do what you want. And sometimes you get less issues with movement patterns at that time. And so hopefully those types of these devices are going to continue to work on. The problem with EMG is it's a fairly noisy signal and it's hard to interpret exactly. So another type of signal is EEG. And this encompasses the brain-computer interfaces. And this type of device uses the brain's motor intent to control the device. There's not a lot of these that are out at the moment because sometimes they're non-invasive, and you see non-invasive ones like caps with a bunch of wires that lead off of the head, or you've seen ones that are now working toward implantables where you implant them in the body to either stimulate the motor cortex or decode the motor signals. So, you know, a lot of this EEG type research and use of these devices have been used mostly to work on controlling computers or controlling robot arms to help. But the implantable ones are things where it's getting to be a little more motor intent and easier to work on. Well, I won't say easier, harder to work on, but hopefully more activity that's going to be promoted from this. So one of these, and I'll give you one example, is called the Synchron Stentrode. And this is like a stent that is an endovascular neural interface that records this and streams the brain's activity wirelessly to a software platform that they have. And then it translates these data to standardized digital language that is used by apps for communication and control of external devices, such as computer input devices, what they're really working on trying to access. But in the future, could some of these types of things activate the motor cortex to then control a power wheelchair or even an exoskeleton to allow someone to think the movement versus having to put the effort in and risk having some muscle substitution issues. And these are starting to be studied now. And I think there's promise coming forward with this. One of the other ones that is in the market currently is made by Cyberdyne. And Cyberdyne has something called HAL, which is the hybrid assistive limb. And they have a different motion principle. And what they do is they think, and the brain generates command signals. It sends those signals to the muscles, and the muscles receive the signal. HAL then reads the signals and then moves as the wearer intends. And the information is then sent back to the brain. That whole process pretty much describes the process of neuroplasticity. And Cyberdyne is using what they call bioelectric signals, and they travel through the skin and the tissues. So, but the hard part I've found with this particular device is it needs a lot more training to get more prolific with the device. But again, something that's working on motor intent versus force intent. So when we look at all those different opportunities, what is really the future of robotics? Well, the current data shows that once they leave their rehab, many patients fall back to the outcome level of conventional therapy. So what's needed then? Is it possible that they need more home-based devices to continue to grow their rehab and keep up the intensity they were doing while in the program? Does that have to be socially acceptable to use those things in public? Just think what a patient wants to do for getting up and using the wheelchair. It's hard. There's more sharing in technology through global collaborations of joint labs to enhance development of future robotics and platforms for delivery of service. And that's seen here, driven by Fourier intelligence. There's big data, and robots can do one thing that humans cannot do very well, is collect a lot of data. Use of data and AI will drive clinical treatment pathways and outcome predictions, and this may affect how we currently deliver rehab services, and then ultimately how we're reimbursed. And the newer control systems which utilize motor intent drive the actuation of the robots. So what are we doing? We're helping to try to provide that efficacy. So in conjunction with Marco Santello and his team at ASU, we are working on investigating whether upper extremity robotics using the Fourier arm modus M2 show efficacy in use when added to the conventional therapy routine. In this proof of concept study, we're trying to discern what is that efficacy. The problem with some therapy in the US is we have certain study parameters, and we've incorporated this into our study. The insurance limits the number of sessions available. You can't just do a study that has 70 sessions when you don't get that from your insurance. We're looking at chronic hemiparesis, use of TMS to make sure that we have the cortical spinal tract intact that shows better outcomes, and also randomized conventional therapy versus robotic therapy. And for this study, it will consist of 12 subjects, 6 participants randomized in each of the robotic and conventional groups, and we use different outcome measures to measure things like the Fugl-Meyer, range of motion, manual muscle testing, TMS, and the Borg scale of perceived exertion. We're hoping to have some results next year at this time, and we can display some of those results for you. I'd like to show you a couple reference that we had from Dr. Weinstein's presentation from the Stroke Association. And I'd like to really thank you for giving me this time and opportunity to speak at your conference. And I wish you all the best.